to the next one, and thank you, Rohit, again. Let's move on to Partha, who has been spearheading education, and we are very lucky to have him as the helm of our scientific program committee and so on. So, Partha, please go ahead.
So thank you very much. And it's a great pleasure this morning that you are there chairing this session. And this is a session where Dr. Namrata has really well designed it. Especially, I chose this topic, and it is pediatric eyes. So I have named it Light a Candle for Tender Eyes. And I am very, very happy to say that you have been an inspiration for my graduation into pediatric cataract surgery. It has been a long, long way. And we do understand that there is a huge burden of pediatric cataract all over the world. And if you look into the literature, the burden has been nearly 1.4 million. And 1.4 million eyes with pediatric cataract. And if the pediatric cataract surgeons in their own accord are not able to perform this huge number, it has to be the cataract surgeons who have to actually take up the burden as well. And it is not a difficult learning. It just needs to be meticulous. It has to be learned. It has to be initiated, and then the more difficult surgeries also can be taken up. So what is different from an adult cataract? The first thing that is different is, of course, the anterior capsule. And the anterior capsule is very, very tensile. And the capsular rhexis, as we see, has to be initiated. And all the time, centripetal pull is the key point. A good viscoelastic cover, optimally filled in the anterior chamber, is important. And that can help in doing a very, very nice and meticulous circular anterior capsular rhexis. The next part is not difficult, taking off the nucleus and the cortex, which is very, very soft. And it's just like an adult soft cataract. But the next part is again a little tricky. So again, an optimal fill of the anterior capsule within the anterior capsule, and then initiating the posterior capsular rhexis with a cystotome. The microrhexis forceps is a must. And here again, the pull has to be such that we create just about a 3.5 to 4 millimeters of posterior capsular rhexis, which is mandatory. The next part is also not so difficult, inflating the anterior capsule to the posterior capsule and then placing a single piece lens inside the bag under direct visualization. The leading haptic has to go inside that space that has been created between the anterior capsule and the posterior capsule. And lastly, when everything is in the bag, then the posterior anterior vitrectomy needs to be done. But let's see a few of the more difficult cases, and one by one we can take up if we have learned our first steps. So this was a rubella cataract. And as you can see that there's a lot of opacified material and also a plaque that there is. So the cortex is more dense. Here we place a 3-piece lens in the bag, but this has to be negotiated. The posterior plaque that there is has to be negotiated, and which we do with an MVR blade. And then going on to the posterior capsular rhexis, capsulotomy here with the vitrector. The vitrector has to be used, and we cannot do it with the cystotome or the pull. And of course, we need to ascertain whether there has been a vitreous loss with tricot. This again is a challenging case, and it is a microcornea with a cataract and a coloboma as well. So placing a high molecular weight viscoelastic in the area of the coloboma is mandatory so that the trypan blue does not go into the posterior chamber and stains the vitreous. So as you can see again, this is a tough scenario where the anterior capsular rhexis has to be adequate, and it is nearly going to the extent of the placement of the anterior zonules. And again, the posterior capsular rhexis has to be initiated. This again, under direct visualization, a very good microscope is very, very important, and optimal fill of the anterior capsule, the bag. Placing in the single piece lens, this lens definitely comes in, but the bag has to be centered. And then we need to put in the CTR. Once the CTR is placed, the centration becomes much easier. And then the last step, and that is the anterior vitrectomy. Let's look at this scenario. Again, what is different from an intumescent cataract in a pediatric case? So again, the tensile bag and the tenseness, and you can see that the fluffy cortical matter exuding out. So we need to take it out. And again, here the anterior capsular rhexis has to be as perfect as possible, remembering the fact that these anterior capsules are going to be there, going to opacify in the next 60, 70 years of this child's life. So removing the whole of the cortex, and we do feel that the anterior capsular rhexis has not been done as well as it should. The posterior capsular rhexis is done, the lens goes into the bag, but you can see that the anterior capsular rhexis needs to be modified. And here a little snip with the micro scissor, and then round off with the micro forceps from the side. And at every step, it is necessary to place in high molecular weight viscoelastic or methyl cellulose as and when necessary. Let's come to this last case. And here, this is a case of a posterior lenticonus. Again, we do know that a posterior lenticonus would have a dehiscence of the posterior capsule unless otherwise proved, and we would be expecting this. So it's important that we do not do a hydrodissection, and I'm manually separating out the anterior capsule from the nucleus matter. And I'm definitely hoping that we have an intact posterior capsule, but you can see that there is a plaque right center in the posterior capsule. And this plaque is actually saving the grace of the day. So we do a posterior capsular rhexis, keeping the plaque right in the center. Now, this is not so difficult as it looks, but the grasp and the regrasp of the microforceps has to be as accurate as possible. And this we do. And then with an anterior vitrectomy, we have a neat circular capsular rhexis, posterior capsular rhexis, the lens being placed inside the bag. And this completes the case. So what are the pearls of a pediatric cataract? By a comprehensive ophthalmologist. We are all good cataract surgeons, but we need to take up the challenge of a pediatric cataract as well. So a detailed preoperative examination, an accurate biometry, a very accurate rhexis. The posterior capsular rhexis is important. The IOL must go into the bag, and an anterior vitrectomy needs to be done. The postoperative inflammation needs to be controlled, and amblyopia therapy has to be done. Lifelong management, and it is for these tender eyes that would they see the light of the day and the light in the future. Thank you very much for your patient hearing.
Excellent presentation, Partha. You covered everything in such a short time. So lucid presentation. Thank you so very much. Any question on this?